Hello, everybody. This is Sarah DeSilvi, Terminology Director of Transferring from the Pilot Affinity Call, which was just a few seconds ago. We're going to let people roll in and we'll start probably in a few minutes. And thank you for your patience and welcome today. It's going to be fun to have this call with you today. Again, just noting we'll start in a couple minutes. We're just going to let people roll in. Many of the Gravity team members themselves were just at the previous call a couple seconds ago with pilots. And so we're all going to roll in shortly. All right, so I'm going to start in because we have a fair bit of things to cover today, and usually folks roll in, and I would love to see if we can finish the top of the hour today. We used the whole an hour and a half last time, which we don't always do. I'm going to kick us off and then allow people to come and enter as we go forward. Again, this is Sarah DeSilvi, the Director of Terminology for the Gravity Project, welcoming you to the May 25th meeting for the Public Terminology Call. We'll be focusing on digital literacy and digital access concepts. We are so excited you are here, and we look forward to the conversation. Next slide, please. As always, and this goes with most of our meetings except for the IG call, so due to the fact that attendees can be numerous, everyone comes in muted, and then we ask that you remain muted to avoid background noise. The call is recorded. Every call is across our work streams, and recordings are always available on the Gravity Confluence. We do work the chat very actively. I try to note everything going on in the chat and make sure we pause conversation and integrate thoughts and comments. And if there's a particularly lively topic, we unmute and have that concept there. So just because we're muted now doesn't mean we'll stay muted. Certainly our subject matter experts will be commenting and participating as we go forward. Whenever you do send a chat, please send it to everybody just so that we can make sure that everyone sees and so everyone can be included in the thoughts that are happening in the chat. Next slide, please. These are the common Gravity Project antitrust practices comments. So Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. Any individual speaking or providing written communications shall refrain from any discussion which may provide the basis for an inference that they have agreed to take any action relating to prices, services, production, allocation of markets, or any other matter having a market effect. Participants shall not discuss their pricing or others' pricing, or any term that might affect pricing or fees, such as costs, discounts, terms of sales, or profit margins. And adherence to these guidelines involves not only avoidance of antitrust violations, but avoidance of behavior that might be so construed. And I'm trying to pet my cat and keep her out of the picture. So sorry if you see me trying to keep a very tenacious tortoise shell out of the meeting today. Next slide, please. This is our agenda. We're going to go through some announcements. For those of you who are on the pilot call, we covered some of these there. We're reviewing project schedule and overview. We'll then go in to a deep dive on digital literacy and digital access comments. And then there have been some updates since we last gathered a year ago. So we're also going to present some revisions and comments of possible definition revisions at the end. And then, as always, we close with community homework and next steps. Next slide, please. Announcements. Next slide. All right, so these are announcements across our work streams. So the first announcements are for the technical work stream. We just want to announce that at the STU 2.1 updates coming soon. Public comment will be for 2 weeks starting the end of May. Publication is expected in late July. And if you want to participate in the implementation guide crafting and work, you can best find that in the public meetings that happen on Wednesdays bi-weekly from 1 to 2 Eastern Standard Time. And then it used to be that we tried to condense everything into this meeting. However, we noted that we wanted to center technical conversations where they would able to be applied to the IG. And so we really encourage you to have those technical conversations in the IG meetings and in the pathways for engagement in the IG, such as DARE tickets or Zulip, just to make sure that everything can be registered. We also want to note that there are 2 Connectathons coming up. One is the July CMS HL7 Connectathon. It's a virtual Connectathon and it's free to attend. We really want to make sure that anyone can participate and engage. It's July 18th through 20th. And then there's also the September working group meeting. This happens from September 9th through 15th in Phoenix, Arizona. More details regarding Gravity announcements can always be found on the Confluence page. And next slide, please. These are 2 announcements regarding policy elements that are really critical. We do try to make sure that we're bringing policy comments. And again, apologies for anybody who was on the pilot affinity group, but this needs to be repeated here in case folks were not there. These are 2 policy announcements. We are a community. Ways to engage in policy are through responses to federal comments. So this is the way to engage in them. So first is the ONC Health Data Technology and Interoperability Certification Programs, Updates, Algorithm Transparency, and Information Sharing Proposed Rule. As I mentioned on the pilot call, it's a very, very long name, but there's a lot of really critical concepts that relate to Gravity and our work, both from a social justice, AI element and patient rights, but also specifically regarding raising the baseline version of the United States Core Data for Interoperability from version 1 to version 3. Of note, that would therefore include Gravity standards. So everything that we curate within VSAC, within our activity standards and our value sets, that would be part of that raising from V1 to V3. So you can follow the link right there, get directly to the topic to add comment. Comment is occurring from June 20th to June 23rd. And just a note on why this might be important. When we think about the drivers for implementation, we were just talking about this in pilots, right? Drivers are in the cacophony of everything. Drivers are regulatory requirements or quality measures. There has to be usually some incentive to make change. So this is a regulatory requirement for using the social determinants of health terminology that we collectively craft here is a really critically important thing to weigh in on to advance the dial, right, to move us forward in implementation. Another really critical policy statement that's really important for, again, because we talk about the effects of the data that we create, is the HIPAA privacy rule notice of proposed rulemaking to support reproductive healthcare privacy. When we talk about addressing and building data within the terminology division, one of the things that we talk about is addressing the injustice of invisibility, right? So being able to tell critical stories by building terminology to fill gaps. One of the risks of having things be made visible is the use of for harm or bias. And this is why that critical last principle that we have in Gravity is ever so important, preventing, reducing, remediating harm. So in a post-Dobbs world, ONC has authorized that pregnancy status is a critical element for USCDI, but we want to ensure that there's protection so that pregnancy status information is not used to harm the patient. So there is an updated rule that's out in the ecosystem to strengthen privacy protections, prohibiting the use or disclosure of PHI by a regulated entity for either of the following purposes: a criminal, civil, or administrative investigation into or proceeding against any person in connection with seeking, obtaining, providing, or facilitating reproductive health care, where such health care is lawful under the circumstances in which it is provided, I am definitely not an expert in this. I've mentioned this very critically and importantly. There was a lot of information available at the hyperlink. It just is incredibly relevant. The public comment is from June 16th to, it goes until June 16th. We encourage all of you to share it, especially among your reproductive justice pathways and in pregnancy advocates and abortion rights advocates, just because it's very apropos to this moment in time. As with, again, any of our announcements are available on the Confluence and can be found there. Next slide, please. And this is a grant I just announced also on the Pilot Affinity call, so it's a repeat for some. Siren has a grant. It was a new grant opportunity. It's focused on supporting and strengthening partnerships between social care researchers and community individuals. It's designed for social care researchers and their community partners. And they strongly encourage joint applications with separate budgets to ensure fair compensation and distribution of funds. There's an informational session. All of this is available at the hyperlink there on June 6th from 11 a.m. Pacific time to 12 p.m. Pacific time. Applications are due June 31st. We wanted to make sure we got it out into the ecosystem. All right, I think that's announcements. Next slide. All right, so this is just an overview again of who we are and what we do. We are a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide, please. Our use cases are important when we're considering terminology development. This is our goal here in this work group. It's documenting social care data, patient-client encounters, tracking social care interventions to completion, and gathering and aggregating social care data for uses beyond the point of care. Again, all of this can play into the why of our 4 activities that we curate data for, and the why of what we'll do today in the call. Next slide, please. All right, I mentioned these earlier. These do definitely relate to the policy statements that were there before, but as we go forward in our build, we just try to ground ourselves in our principles. They are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. That is most importantly the bullet and principle that I referenced regarding the HIPAA refinement to encapsulate a post-Dobbs world. So that's, again, the risk of being made visible and how we prevent, reduce, and remediate harm from the data that we create and share. Next slide, please. These are our amazing members for 2023. Ever so grateful. If anyone's ever interested in becoming a member, please reach out and let us know. Next slide. And then this is the roadmap. Next slide, please. So we are here in May. We are kicking off or deep into the work of digital access and digital literacy. There's a lot of proposed work that we're trying to figure out how we'll address. We're working through our member-driven committees in order to figure out where they will be on the roadmap. These are expanded material hardship concepts, with transportation insecurity concepts, and possibly working on HCPCS codes to encode food services delivered, which we know in the ecosystem is really critical for CBO sustainability and some of the novel partnerships that are there in the ecosystem, whether it be in lieu of services or CalAIM or the implementations in Massachusetts. There's a lot of use cases for those HCPCS codes. So that's one of the things that we're thinking about developing. The STU V2 1.1 update is almost complete, as I mentioned earlier. Public comment will start shortly. We are doing some new use case development in partnership with MITRE regarding eligibility of social care services. We got through our HL7 Connectathon. We're aiming for the CMS Connectathon, as I mentioned. And in the fall, you can see that FHIR Connectathon. And we are knee deep in the public health and health equity use cases in partnership with our friends at Civitas. We are about to engage in an initiative specifically focusing on CBO engagement regarding our products and deliverables to make sure we're meeting community-based organization needs. We are busy. We are incredibly grateful that you're here. And it's going to be a busy 2023. Next slide, please. Any questions on that? It sounds like we're doing pretty good. Welcome to the core terminology, folks. Next slide, please. And next slide. I'm going to pass the mic to my colleague, Himali. There's been some pretty significant updates in our approach to value sets that were part of our glide path of how to make value sets in VSAC more useful and more relevant to the IG and specific for the IG. And Hamali is going to talk briefly about those because it's really critical from both the terminology implementation perspective and the IG. Hamali?
Thanks, Sarah. So in the recent update to VSAC, we are focusing on adding 54 new screening assessment related value sets in VSAC. And these value sets are evolution of our current existing value sets, which are at screening assessment level. These are panel level codes that we have added last year that represents over SDOH screening assessment value set that includes panel level code that we have used across all 17 clinical domain, as well as domain specific screening assessment value sets such as social connection screening assessment, which represent all the screeners or screening instruments that has been identified for social connection domain through Gravity Public Association. We realize that it is critical that public should have access to specific questions and answers within that panel codes, because not all questions in a given panel codes are used for a specific clinical domain. So based on the need of the community as well as implementers, we have started granulating those high level value sets into a smaller subsets where we have created a Uber value set for all screening assessment questions that represent questions for across all clinical domains and associated answer value set. We have also grouped assessment, which is panel level codes, and question level codes value set together, because that is the value that can be used into observation.code in the FHIR IG. So we have developed a SDOH Uber value set for these three categories, as well as we are replicating that effort across all 17 clinical domains, where we will have domain-specific screening assessment questions, domain-specific screening assessment answers, and domain-specific screening assessments and question value sets. So this is a work in progress, and it's a huge addition to our existing 159 value sets. So it would be 159 plus 54 value sets, and we are working diligently towards it and hoping it to be out in a month or two. So that's a quick update on the terminology build. With that, Sarah, passing it back to you. Thank you.
Hamali, I just want to give a nod to the amazing Hamali Sejwal, who's along with Monique Van Berkom from the AMA are leading this work. I know it sounds incredibly meticulous, but these value sets curating the specific questions and answers are really such an advance from what we have been able to curate in VSAC. Is an incredible amount of labor, and just very, very grateful. And it actually supports, again, it just supports, integrates so importantly with the implementation of the implementation guide. Incredibly grateful. Thank you, Hamali.
Thanks, Sarah. Also, Asha is helping us.
Oh, Asha too, my apologies. I know, I'm sorry. You can tell my brain is tired. No. I've been talking for a while. Yep. Thank you. Yeah. All right. Next slide, please. All right, next slide. So we're going to go now deep into terminology development specifically for digital access and digital literacy. We have many of our subject matter experts here. I'm trying to get in, and I think I did. I got to a point where we could include one of our subject matter experts who has to leave a little bit early. And so again, here we are in the glide path. I mean, the process of how we develop terminology. We're in the identification phase. We then go into review, where we make sure our value sets and master lists, our master lists are complete. We then vote on them, our master list, in order to make sure that they're sufficient. Not missing anything, that nothing's incorrect, that we can either fix anything or take anything out. Our job then in terminology is to analyze those master lists, that desired list of things, and then work with our terminology standard organizations to build those into the ecosystem, whether it be IC10-CM, LOIN codes with the registry for SNOMED CT codes, or even CMS with HCPCS codes. We then test them and then evaluate them. So here we are in identification phase, doing our work with digital access and digital literacy. Next slide, please. And we are in our second meeting, so we hope to complete this work through the middle of August. Again, identifying concepts for the first few meetings, accelerating that work, then going to end-to-end review through the end of July into early August, and then having the vote at the end, I mean, the middle of August, so that we can have a small break at the end of the summer before things kick off for school again. Next slide, please. I just wanted to ground everybody in the process again. So we meet weekly with our subject matter experts to review validity of submitted instruments and craft domain aligned terms for diagnoses, goals, and interventions. These items are then moved to the master list for community review. So all the work that happens with SMEs is kind of the sandbox, because we have to do all of their adjudication from an evidence-based and expert perspective, and then we add terminology and informatics expertise. And then when it hits the master list, it's available for public review and download. And then things that are of note are discussed here in the biweekly public call. Next slide, please. We're moving methodically from screening instrument identification toward interventions, just in sync with our gravity model, but things might get mixed up a little bit. The first content, we're reviewing our instruments. There's more to come, but just want to let you know that we're deep diving into instruments first. Next slide, please. You can find all the master list on the Confluence page. So if you go to the Confluence, the drop down on the left is how you find digital access and digital literacy. Oh, we can definitely, Gravity project at hl7.org. We'll make sure we drop the email in the chat, Jonathan. It's really wonderful that you want to submit concepts. We love it when the public does. And that's part of our homework at the end there. So on the Confluence, you can see digital literacy and digital access are the last domains in the initial social risk dataset specification list. We renamed that because we now have a section. We really want to make it clear that there is a section for implementation and a section for build. So this is where you find the build, the work we're doing now. Masters will come by the end of day tomorrow to the Confluence page specifically for the domain. And you also will be able to find definitions, instruments, hyperlinks, any kind of detail you need in order to adjudicate, in order to understand and interpret the masters. That will happen on the Confluence as well. Thank you, Sarah, for dropping in the email. Next slide, please. And next slide. Super grateful for amazing subject matter experts who are diligently working through everything. Next slide. Just a reminder of our approach. Digital literacy was pulled from our work on health literacy as a unique aspect of concern. We have to, again, consider personal and organizational sources and need to consider different aspects and skills. You can see those both in our presentation here, and eventually they'll be on the Confluence. And then access is pulled from our work and material hardship. We have to, again, consider environment. It's not present, and financial resources. I cannot afford it as differentials there. Next slide. And then I'm just going to try to make sure we have a little bit of time to center Dr. Aguilera, because we were talking about the intersection of digital access and digital literacy on the in our subject matter expert meeting, and the importance of assessing digital access prior to digital literacy. For example, many of the instruments we're going through right now ask, are you able to? And unless you assess whether you mean, do you have internet? It can mean, do you have internet? And then once you have it, you're able to use it, or it can mean that you don't have it. And so I was wondering if we could snag him. He has to leave in 6 minutes. If Adrian, you could speak briefly to the intersection between digital access and digital literacy before we lose you.
Sure.
Thank you.
Thank you, Sarah. During our discussion, one of the things that we discussed was that often digital access is a prerequisite for digital literacy, at least when it comes to different types of interventions or using technology either at home or via one's phone. There are some cases in which it may be a little bit less of an issue if you're using technology, in a healthcare setting. But it does seem, as we were going through these questions, that digital access is really important to assess before, because then it's going to provide context for any following digital literacy content, that digital literacy data that we can collect.
Thank you so much. One of the things I'm just going to note, and Walter, actually, I'm going to let you talk, Walter, and then I'll go. Walter?
Well, yeah, thank you. And thank Adrian for that point. One of the things that is important to consider is the actual definition of, or the subject matter content of each of these two concepts, because traditionally or more commonly, digital access has been focus on the concept of access to broadband services, access to the internet, but there are a few other components of access, which includes access to digital technologies, because people can have a very good internet connection, but if they don't have the good elements to interact, whether it's computers or iPads or phones or some other mechanism, then that's a challenge. And there's also access elements related to the quality of the the resources. So I just wanted to highlight that point. And then on literacy, there's also, and going back to Adrian's point, the connection about you can have excellent broadband access, excellent tools like phone or iPads or other things, but if you don't understand, or if someone doesn't really understand how to use them, then there's that challenge as well. And then there's also digital literacy with respect not just to the tools and the broadband services, but also information. The ability to understand and to process information that is in the digital space. So I just wanted to highlight a couple of those elements that we're looking at as well in this instrument. Thank you.
Thank you so much. Any other comments on the intersection of digital access and digital literacy at this time? I just want to, if there's not, I just want to note a precedent. So one of the things that,
Sarah?
oh, hi, hello, Lucy. Yes,
Hi, sorry, I should raise my hand here.
no, that's
but,
okay. Here we are.
I'm wondering, is there a distinction to be made between the patient in front of you having digital access and possibly digital literacy, and the patient context where somebody else might own the platform, regulate or specify times of access or frequency of access, and then help with digital literacy? In other words, are we talking about individual people here, or does it make sense or not to think of a context where there might be access and literacy, but it's not the person sitting in front of you?
Does a subject matter expert want to reply to that question from Lucy? Or maybe Lucy, can you help me? I just want to make sure that I understand. You're talking about the organizational elements that we were talking about before, like the.
No, I'm thinking more of the patient situation where there might be a grandchild, say, who understands, a grandchild who has to be there helping all the time, might even be in the visit, or another person in the family. I'm just trying to understand whether the target for talking about these concepts is an individual who may or may not have them, and then what do we do? Or an individual within a social context where both access and literacy may be present, but the individual isn't the primary agent. Is that?
That makes a lot of
Yeah.
sense. And I don't know if our instruments are subtle enough to capture that so far in our assessment. Now that I understand better, any other comments from our subject matter experts? It looks like both Walter and Jorge have things to say about that. Walter, your hand was up. Did you mean to put it down, or do you have something to respond to Lucy?
Oh, yeah, no, thank you. I will mention a couple of points. That's an excellent observation. And I think this is somewhat similar, although different, but parallel, if you will, to what we have in privacy with a personal representative that acts on behalf of someone and makes some decisions or determinations. In this case, I think it's a very important point that, it's necessary to consider the possibility that individuals depend on others in order to execute. For example, when there are disabilities as well, and if there are no ways to interact, even though you have the best, internet access and all those things, there are other elements that might contribute to the inability to interact digitally. So yeah, I think that's an important point. And as you point out, Sarah, I think the instruments are not refined enough to go and dig deeper into that element. I agree.
Jorge?
Yeah, just piggyback off of that, I think, we often encounter this on the healthcare system side, especially like when it comes to patient portals as it relates to like proxy access and what that looks like. So that's sort of one kind of granular example of why it's important to assess that point that I'm glad you both brought up. So I think it'll help us. I think there's some. Yeah, some of that, I don't think they explicitly, but there might be a few of the instruments, a few of the questions that might get at that there, but I think it'll be a good ping for us to kind of keep that in mind moving forward as we start looking at some of these questions a little bit closer. But that's a great point.
I want to thank Lucy for always bringing in the patient voice. And so I have two things I'm thinking of. Number one, I think, Lucy, about how that relates to what we know we learned when we did health literacy, right? How we're talking about what the barrier actually was and whether there were questions and outcomes that could highlight that barrier, and then how our interventions need to be directed to directly address that barrier as well, right? So I'm thinking, of course, of what we did last year with health literacy, and that in the continuum of how you identify the proper place, the right problem and the right intervention to solve the problem. Because that's work, again, we did with health literacy. I'm also thinking a little bit, because of this intersection, what Adrian was talking about, of the importance of assessing digital access prior to digital literacy, about some of the work we did with intimate partner violence, right? About how knowing the critical nature of setting the stage, like how we ensured that there was a right way to set the stage to ask the questions, so you got the right information for everybody. Lucy, it's nice to see your face. It's such an intimate group, and here we are, right? So because in our work with intimate partner violence, there was a best way to ask, so you got the best data. And so we built that method into as a preferred instrument, right? And the start of the instrument was just a phrase. It's important to think about things these ways. And then that was such an important preface that we replicated across elder abuse as well. So this is all super, super critical. And I think it really helps us figure out the intersection of digital access and digital literacy as we try to figure out build. Any other comments specifically on this? We're about to go into instruments specifically, but any other comments regarding the interrelationship between these two concepts and important perspectives on how access is being accessed or how literacy is being addressed? Yes, Walter. Yeah, great. This is, again, if you look at we'll review collectively some of our interventions for health literacy, and we absolutely had to think about pathways where family members or advocates or care team members or even a designee is the person who's interacting on behalf of the patient. So we can pull that some of that learning forward again. All right, next slide. Now on to digital access. Next slide. This is our work in progress definition. The brilliant subject matter experts will help make sure we get it right over the course of time. Highlighting again Walter's ever so important statement that it's not just access to the high-speed internet broadband, but it's also the tool to use it. Of course, thinking about what we were just talking about, there's a lot of laptop sharing in the ecosystem that I work in deeply rural Vermont, and even cell phone sharing. Most telehealth visits in rural Vermont happen with a family member going over to a patient, like an older individual's house, with their equipment to assist the family member in access. So again, everything we were talking about makes a lot of sense when we think about this term. Next slide, please. These are some of the instruments that we're pulling forward again. So when we think about the work that we're doing, the subject matter experts are helping us adjudicate things, because again, the base requirements for Gravity instrument inclusion is that it has to meet face validity. You have to be reliably able to get to the concern from the question. So we have the educational impact due to COVID-19 panel. Do children in this household have access to the internet during the day to support learning? What types of internet do children in this household have to support learning? What following devices does your children in your household use to access the internet for learning, etc.? How many laptops or desktops do children in your household use for learning? The reason why this one is important is digital access is not just a healthcare problem. There's lots of like access to telehealth questions we're discovering. This is a really good example of a question that's related to learning access. The American Community Survey is an instrument that we assessed also on Tuesday. We heavily lean into any federal instrument, and these are some pretty critical questions that came out of the ACS. So at this house, apartment, or mobile home, do you or any member of the household own or use any of the following types of computers? And there's a whole answer list that I don't have on here yet. At this house, apartment, or mobile home, do any of you or your members of this household have access to the internet? And then do or any member of this household have access to the internet using a blank? And there's a whole answer list that is, again, not included in there. So by tomorrow at 5, these instruments will be available on the master list for individuals to review. There also will be copies of them on the Confluence for review. Again, this is the initial list that we're collating. Next slide, please. And then this is the Zuckerberg San Francisco General Hospital Digital Needs Screening Tool. I'm going to ping one of our subject matter experts, Jorge, to talk about this a little bit because he had a really critical statement when we were assessing this. So first of all, this talks about, do you ever go online to access the internet, such as for online searches, send or receive email, or to watch shows, movies online, and then indicate what you have, right? So that's, again, that other part of access. Specifying smartphone use, specifying basic cell phone or flip phone use, specifying computer or laptop use. And then, do you have concerns about the cost of connecting on the internet? And then, Jorge, if you want to briefly discuss your comments regarding the scarcity and importance of assessing cost as a barrier to digital access, that would be really great, just so everyone can learn with you and from you on that. I told you I'd ping you.
Yeah, no, I'm ready for it. Yeah, so I think the cost question, I think I did a really good job of highlighting this, because I think, having access to it is one thing, but if you're sort of struggling to pay for it on a month-to-month basis, I think it's access, but with like an asterisk almost. So I think it really highlights that piece of it in terms of like having reliable and affordable access to internet or to devices. And I think the other thing it highlights is, a lot of the reasons we probably ask a lot of these questions is because we feel like there's hopefully something we can do to address the gap, right? It's with a lot of these social needs assessments, or what the goal is. So here, for example, there's a bunch of different programs. The one that's currently kind of top of mind is the Affordable Connectivity Program. And so it kind of clearly connects a bit to that, where it makes it a bit more actionable. And so I think that that's why I like this question. And I see Amy. Hey, Amy. I see Amy asking a question. Hey, Amy, good to see your chat.
Hey. Yeah, so I was wondering if the device questions are specific to a device owned by the respondent, or, might they say yes if they occasionally borrow their ex-sister-in-law's device?
Yeah, that's a great question, and I think to some extent maybe ties back to that initial point brought up by Lucy around like proxy access and shared. What if one person has access to it and the family maybe doesn't? So I think that's a great point. As usually, I think it's important for us to kind of think about a bit more as we kind of dive a little bit deeper into the questions. It would be my thought.
One of the things that we note in our current definition, and this came out of early conversation with our subject matter experts, is the parenthetical reliable. So it's not just access to it, but reliable access, right? And so, one of the things that might happen as we work in this ecosystem, we haven't reviewed all the instruments, is we note gaps. We did that in certainly in food insecurity, because even though we note that cultural appropriateness is a critical aspect of food insecurity, there was no good question for it, right? So there's a really critical element of the domain that we all recognize, cultural appropriateness, but there was no question. So there's this huge space, and there's a lot of research at Tufts regarding cultural appropriateness of food and the lack of standardized assessment of it. So there might be part of this as well with our work, where we identify questions that need to come. And luckily, many of our subject matter experts are researchers. So maybe that will help them refine tools that they have in the ecosystem and participate in for future work. This is the benefit of working with top experts in the field. Just wink, nod to the SMEs on the call. Any other comments or questions regarding this instrument and cost? I hearken back just to one other thing too that we remember from food insecurity as well. Way back in the day in 2019, when we kicked off, we were talking about the truth that many barriers can be overcome if you have enough money, right? So even in rural Vermont where there's no broadband, if you have a dish on your home in the mountains, you can access internet fairly predictably. So this importance of assessing cost is pretty important. And like, even if you live in an area with poor food access, if you have sufficient funds, you can have Blue Apron deliver you your food to your door. So cost as a mechanism to address access and resources, financial resources, and mechanism to address access are ever so important across every one of the domains we work on. Lucy's asking a really good question. Again, this is a great rural Vermont question about when power goes down. Is there a screener for has this ever happened? Did it affect your access to use of services? This happens. Of course, it happens directly related to inability to afford electricity as a material hardship and related to rurality. Often wondering if SMEs have any answer to Lucy's question regarding power and access and how electricity and access and to digital access and how they interrelate. Or maybe that's another area to be determined.
Yeah, I'd say it. I don't know. I'd say it perhaps connects back to like the emphasis on like the reliable piece, which I think maybe connects it without getting too nitty gritty into like the access to electricity overall, which could be like a problem for all sorts of keeping medications refrigerated, all these other kind of things. So I think that's what I would say.
Walter?
Well, no, actually, Jorge just highlighted that point because I think the point about electricity is far beyond, I guess, or it's a much larger question than just purely as it relates to digital technology access and all that. So I think it is something that needs to be on the higher level type of questions that are looking at more basic service elements, I guess, or basic elements, I guess, that are needed for many other things, including, as Jorge mentioned, maintaining refrigerated food and other elements. So yeah, thank you.
And then Amy has a really good comment regarding Digital Equity Act and digital inclusion, referring to personally owned devices, increasingly important due to two-factor authentication. And then Jonathan responds specifically as it relates to HIPAA and PHI, ever so important. Jonathan, thank you. Kate talks about highlights the cascade or interdependence of our determinants. Yeah, we talk about the Venn diagram of things often in this call. And then Teresa's elevating the fact that all of this is ever so more important when we're talking about remote monitoring and equity in healthcare access and how digital access and healthcare access interrelate when it comes to remote monitoring devices. Ever so important. Thank you so much. You can tell this group has been around for a while. Thank you. Next slide, if we're okay, moving on. I can't believe we've only have 15 minutes left in the call. Digital literacy, moving on to digital literacy. Next slide. So this is the definition and process, which is the ability to use information and communication technologies to find, evaluate, create, and communicate information, acquiring both cognitive and technical skills. It's currently based off the ALA. And then Walter, do you have anything to say, or have you not lowered your hand? I want to make sure you're included.
Oh, I'm sorry. No, I should lower my hand. Sorry.
I know you always have things to say. And then we'll get back to you. Okay. And then next slide, please. I just wanted to put this so that the subject matter experts weighed in really brilliantly. And Adriana, who's on the call, was part of that. Boomi, who's not here today, she's at a conference, but everyone kind of weighed in on the slide when we presented it last time. It's difficult to assess digital literacy instruments unless we have those skills and aspects in mind. So I just threw this back up here. Probably it'll have to revisit on a regular basis because it's so complex. And we're also going to put these aspects and skills in work in progress. We can always refine them onto the Confluence page, because again, if I were coming into the ecosystem trying to figure out how instruments were applied, I need to understand the skills I was measuring. So essential computer skills, network literacy, digital problem solving, information literacy, media literacy, social responsibility, and identity security. Not all of our instruments will cover all these concepts, but it is important to think about which ones they do cover, because just as we were talking about above, most of these skills have areas of interventions that are related to them, and we'll have to think about what they are when we build our programs and intervention terminology, right? And we also have to think about them when we think about the instruments and the problems, right? So those skills all being in front of us on a regular basis are important. Any other comments on the skills aspects, Smeeze, before we move on to instruments? We're doing good? Seems like,
Sarah,
okay.
Hi, Sarah. This is Corey. I just have a quick
Corey's
comment.
here. Hi, Corey.
Good afternoon, and it's not specific to the to either domain because I'm learning here, but you know, as it relates to screening, just a comment. I wonder if we should be considering kind of 2 layers of screening. Layer one is sort of an efficient means by which to separate those who have no risk or need for anything from those who have some risk. And then layer 2 of screening may be a more detailed set of questions for those who have risk to better assess what the specific need is. And I think there might be some potential advantages to both the patients who are being screened. For those that have no need, you know, it's just sort of an efficient, okay, you're done. And or risk. And then, you know, also for those doing the screening and don't know how to address the need, you know, maybe providing that layer 1 might, you know, make it less burdensome on them to actually do the screening. So just a thought that probably applies to every domain, but I'm just thinking about it here. So that's all. Thank you.
Yes, and Corey, this is a precedent we have in other domains, and you're aware, right? So we think about the cascade. Someone was mentioning this earlier. Like there's the financial insecurity question. Do you have any problems paying for food, you know, housing? I forget everything in the cardio screen. There's the representative 2 question, the hunger vital sign. That's a snippet of the full 18 USDA food security module, right? But one of the complexities that I'm noticing early in this work is that there are very few brief instruments that represent the complexity of the domain. So yes, there's precedent for that. It's very helpful for implementation, and from a bandwidth perspective, and again, Smeeze, correct me if I'm wrong, I'm having a hard time finding those instruments right now, but it's a really important thing to consider. And we know that the clinical ecosystem requests this. We just had some back and forth with the development of the Transportation and Security Index, who have a large, robust instrument, but because of clinical applications, they're testing a smaller instrument for clinical use because of exactly that need to take a quick pulse and then go deeper. So I'm sorry, that was a lot of talking, Corey, but yes.
Thank you.
And this is Monique. I think one of the challenges we're going to face with this is, you know, digital literacy has definitions out there, like, you know, in the European Commission that, you know, digital literacy for a librarian or a teacher is different than digital literacy for a patient. And when we use things like to be able to create content, you know, digital content creation is one thing, you know, creating if content is an email, but that isn't considered content, that's considered communicating. And so I think that the create piece, we have to be very clear, you know, we're taking a definition that's out there for people often as a workplace skill definition, and we're trying to use it in a context of an individual, you know, interacting with providers and community-based organizations. At least I think, or maybe we're not, Sarah, maybe we're just saying that, you know, this is a skill like employment that, you know, we're looking at the whole gamut of what it means, but it means different things in different contexts. And I think we're going to have to find the right context so that we're not calling individuals not digitally literate because they can't create, you know, content and understand licenses for creating content, et cetera.
Yes, it's very important, Monique, and it reminds me of like the different ways we think about transportation and security, right? Is it just can you get to appointments, right, relative to the healthcare perspective, or is it can you get where you need to go in general? Monique, you're always so good at raising these things. Two-phase screening seems like, okay, this is Lucy echoing what Corey was saying. Seems a great idea for efficiency in care processes. The implication could be centralizing the second screening, a digital access literacy expert covering many clinics, providers, someone with technical expertise to create interventions tailored to specific personal situations. Brilliant, Lucy. What a vision for the future. All right, we're going to quickly get into a couple of the instruments we have here, and then we have some novel updates that we have to address as well. Next slide, please. Unless the subject matter experts have anything else. So this is a specific response actually to what Monique was saying. So this is literacy for a purpose, right? So this is the eHealth literacy scale. This is about literacy, digital literacy, and how it relates to health, right? Specifically, like how useful do you feel the internet is in helping you make decisions about your health? How important is it for you to be able to access health resources on the internet? I know what health resources are available on the internet. I know where to find helpful health resources on the internet, etc. Bumi's not here today, but one of the things that we saw with some of our instrument selection was this idea of like, I feel like I am able. And so in her work in the Wisconsin Health Literacy Network, it's called Tech Tenacity, which I just loved. So this is part of the concepts that we're discovering as we go forward as well. Again, what Monique was saying was regarding like, this is literacy for a specific purpose. Jonathan, yes, that sounds great. Okay, next slide. Again, we do the hours. I do want to see if we can get out within an hour as opposed to an hour and a half. This is an example of an instrument that's massive, right? The digital health literacy instrument. It's beautiful. It has lots of really lovely questions with standardized answers. It would be nearly, it would be challenging to implement as a clinician. As I speak as family medicine myself, but there's a lot of really beautiful questions. So one of the things that we're investigating is whether we have the capacity to pare down instruments to make them fit for clinical purposes, or whether the original authors are already working on doing that, because again, this is a cumbersome thing to implement as it stands right now. I think that's the last digital literacy instrument. Next slide, please. Any other comments from the subject matter experts on what we've covered so far before we pivot and do some general terminology updates before we leave the call?
Just a very quick comment that the smaller group, or the group that is focusing on this, has still a few other instruments that are we're looking at that a number of us contributed with. So the first phase, I think, was really review all these ones that have been already pre-identified, and then our next step is also going to be analyzing some of the other instruments that have been contributed by members of the SME group.
Yeah, so maybe the most clinically brief ones have not been addressed yet because the bigger ones are the ones we waded through first. Walter, good point. All right. And then Lucy's saying exactly what expert doing. Yes, no way. I know, but we don't only include instruments that are relevant in our face validity assessment. We take it off, right? That's our job. We did that with, I think we assessed as inclusive all of the 140 questions of the American Housing Survey in development when we did inadequate housing and housing insecurity. This allows us in later to not have to reconvene the TEP to allow for like brief screening applications, right? So if right now there are some large and beastly elements, and even the perceived stress scale and all of its full form is massive. So we will get to more brief screeners later, and you'll see them bloom on the masters. Awesome. Okay, and quickly going to get to some updates before. I hope it's okay to try to end at 5 today. Just because we don't usually go for the full hour and a half, especially when we're terminology focused. Next slide. Next slide. So this is an update because if we think about ourselves on, I presented that we were in the identification section for digital access and digital literacy. Part of what we know we have to do too is test and evaluate our hypotheses. We have some feedback from the collective after testing our hypotheses. and we're bringing that back to you. And Walter's saying a really important note. There's a lot of conversation about how people are screened, right? So we just did this in my clinic, enabled patient completion of all instruments, either via the portal or via an iPad or kiosk in the waiting room. They're more valid. It's more efficient. It's a lovely way to get access. And we note that in the call there. Of course, challenging and interesting to do with digital literacy, digital completion of instruments, but just note that is a thing there. So next slide, please. There is an update. There's a requested update to the definition for coordination. So when it was implemented into the ecosystem, some of our implementers noted that the definition of coordination process of organizing activities and sharing information to improve effectiveness seemed limited, because effectiveness of what? And we got that comment repeatedly. And so we went back to the source document, which was the AHRQ. And so we are offering a revised definition. And this is going to be present for the ecosystem for a little while. It'll be part of the final vote that we do in August. We're just making sure everyone's socialized to it. So the updated definition that's better aligned with the source document from AHRQ is process of deliberately organizing activities and sharing information in order to achieve safer and more effective care, because that's the whole goal of coordination. We dropped that off somehow from our original definition. And so we're working on this together. Any initial thoughts? Again, this will be in the ecosystem. We'll be mulling it over as we go forward over the next few months. I just love that 4 people are so commented. Improve effectiveness of what? No initial comments, it seems. And so again, we'll have plenty of time to comment on this as we go forward. Again,
Sarah,
Hi, Lucy. Yeah.
Comment. Does acceptable to the patient, is that included in more effective, or does it need to be stated, achieve safer, more effective, and personally acceptable or care consistent with patient preferences or something?
Yeah, I love that. And we can easily add that. That sounds really important. So I think about either person-centered, I think about the preferences work we're doing in USCDI and like patient like goal statements. Let's hash on that together and maybe improve this definition to make it more inclusive.
Great,
There's no reason not to. And so I'll try to synthesize what you said, bring it back next week with a little bit of tweaking and see how we can go forward with that. Because certainly this term is meant to represent a lot of the work that not just care coordinators do, but community health workers do, which is all about what you're talking about, right? Addressing barriers, meeting people where they are, making sure things are acceptable and, and meet the actual person's needs. So it seems really important to include that. Thank you. Any other thoughts? Okay, and then we'll try to make sure that we capture that. And then next slide. One other new thing. So if we're on this previous slide, actually, I'm so sorry. Can we go back one slide? I apologize because I forgot to set this up. This table that you see, thank you, Asha. This table that you see here with assistance, coordination, counseling, education, evaluation of eligibility, evaluation, assessment, provision, and referral are all part of what we call our core activities, right? These are the actions that wrap around our programs and persons in syntax for every domain. Assistance with application for coordination of care plan to address food insecurity, counseling on housing insecurity, education about child and adult food care program. You can tell I'm a food insecurity specialist. Evaluation of eligibility for Supplemental Nutrition Assistance Program, or SNAP, right? So all of those activities wrap around people or programs. Referral to social worker, referral to food bank, referral to WIC office, right? So, or provision, right? So those are our base activities that we all crafted in our first year of work, so that we spent about 6 months just agreeing on the activities that would become the base syntax and meaning and purpose for all of the intervention value sets. And we missed one, apparently, because if it evolved, the ecosystem evolved. So next slide, please. Now we're ready to talk about this. So the National Academies released another report. So for those of us who've been on the gravity, in the gravity ecosystem for a while, we know that the base report capturing social and psychological domains, social and behavioral domains, and electronic health records, phase 1 and phase 2 are our foundational reports that kind of create the structure for our work. There is a recent report called Integrating Social Care into the Delivery of Healthcare that defines 5 core intervention and activity types that the panel of experts deemed were critical for addressing social risks and social needs. And one was adjustment. And it is an activity that we do not currently have in our framework, and we're bringing to the community for reference. Adjustment is when you adjust a clinical plan to accommodate a social risk. The example that I give is adjusting medication doses due to food insecurity, or evaluating or changing a referral site from a preferred referral site to a closer one because of transportation insecurity, or changing a medication from a preferred medication to a medication that someone can afford, even though, the best in class one these days is GLP-1s for diabetes. ADA says I have to give it, nobody can afford it, so I have to put on record that I can't do that, and I have to stick with what patients are on. So this adjustment of the clinical plan to accommodate a social risk was identified by the Academy specialists as a really important social care intervention. We don't have it in our framework right now, so we're bringing it to you all to review, right? So this is, again, something we'll think about as we go forward, and we just want to make sure you all got eyes on it. We can talk more about it as we go on, but again, it came out of the Academy work. Any brief thoughts before we move on? I know it's 5:02. Love this framework, says Ruth. Yes. Again, we'll talk more about it as we go forward, but anything that comes from implementation or anything that evolves in the ecosystem, we want to make sure we get back to you as well. And the next slide. And next slide. Okay, so the Confluence has a host of information. We already reviewed how to submit elements. So we put the Gravity Project HL7.org email in the chat. Send us everything. Send us your instruments, send us your program ideas, send us your thoughts. We'll try to curate them and bring them back next time. We really want to focus on screening instruments, programs used to intervene for both digital literacy and lack of internet access, and lack of device. I'm sorry, Walter, I haven't updated that bullet yet. We also want to make sure that we're including the unique people's roles and professions that are helpers in this space. Please review the Confluence pages. They're works in progress. The master list will be posted tomorrow at 5 o'clock. And then I think I think we're good there. And next slide. Here are our meetings. Terminology is us. Bi-weekly Thursdays 4 to 5 or 5:30 if we need it on Eastern Standard Time. Tech is bi-weekly Wednesdays from 1 to 2 Eastern Standard Time. Pilots is monthly, which is why my voice is going raw. The last Thursday of each month from 2:30 to 4 Eastern Standard Time. All of these are available on the calendar and Confluence. Teresa says adjustment addresses barriers unearthed at reassessments or periodic coordination interventions. Correct, right? Yes. Adjustment can also address an initial interview if you're thorough, right? So if you propose an idea and a patient balks because they have very significant barriers and true barriers, it can happen in that moment as well. Correct. Any other thoughts on anything we've talked about today before we adjourn?
Sarah, I just want to check that the pilots work stream is what Civitas is organizing.
Correct.
Is that okay?
Yes, so it's a Civitas Gravity partnership. So Civitas is helping us with that. Yes.
So that's outside the HL7 platform, right? Or not?
Oh, you mean, is it on the HL7 calendar? Is that
Yeah.
the question?
That's right.
I will check on that and get back to you. I think it's still there, but I will get back to you. Sarah Bahal, do you know, smart woman?
I don't think it's there right now, but we can definitely
Yeah,
look
there
at
you go.
adding it onto the HL7 calendar for more
Yeah.
accountability. But you can also view upcoming Gravity Project meetings on our Confluence, and I'll post the link in the chat.
There you
Thank
go. Sarah Bahal always has the right answer. Any other comments before we adjourn today? Thank you, friends, for being with us today. If you have any friends in the ecosystem who want to come and join the digital access, digital literacy conversations, this is where it happens. We'll see you in 2 weeks, and look for those masters getting posted on tomorrow at 5. There won't be a lot on them just because we're just starting adjudication, but there'll be more as we go forward. Again, they always post the Friday after a public call. Thank you.
Thanks, Sarah.